One of the big reasons why we talk about transgender is because it is a highly sensitive topic, and we need to be prepared in our hearts to deal with this and to make sure that we don't aggravate the situation. So I changed the title just a little bit to say transgender, and we will discuss the ethics, care, and management options. In the first place, please be reminded that LGBTQI individuals are under the spotlight, because in medical circles, in social circles, in media, and in political circles, there's a lot of attention being paid to this grouping of people, LGBTQI. For the LGB group, usually people have gotten used to lesbian, gay, and bisexual. And to some extent for intersex persons, medical care has got a little bit more crystallized, and there are some protocols given, although in some countries and in some communities, there's still a huge prejudice against some of these people. But I would like to point out that it is very problematic for transsexual and querying persons, where there are big differences in communities, in regions, and in countries of the world. Now, transgender persons are seen as experiencing primarily personal and social vulnerability. But we all know that that vulnerability rapidly expands, leading to attitudinal and physical and economic vulnerability. Now, this whole concept of shared problems is evident in all the gender non-conforming groups. And I'm using these words also for you to learn them and to know what we are talking about when we say gender non-conforming, and we will discuss what it means in a second. If I say vulnerabilities, what are we talking about? I would like to put to you that the biggest level of vulnerabilities is at the personal level. So the individual does not identify with the physical gender and sexual characteristics. So a person is born and then gets assigned a gender, like we do, and then as the person grows up, they do not identify with their physical gender and their sexual characteristics. That leads to emotional uncertainty, and it is a big drama. And do you know that in the international literature, it says that there are suicide attempts in 45% of our patients, and people have very poor relationships. And we've seen lots of abuse and lots of heart sore from relationships with these patients. The second vulnerability is a social one, where our people experience rejection from family, from friends, and from society. And they don't do well on the social front. They frequently have unemployment, frequently face dismissals, frequently get the lowest income. They don't get support for housing. And all this is because of their transgender status. It doesn't get better now, because we're now talking about what's happening in healthcare. And I've quoted a USA publication, which is the Transgender discovery survey, which happens every 10 years in the USA. So the last one that I'm quoting is that in healthcare, there are hurdles to access healthcare in transgender patients due to, in the first place, 28% of transgender patients say they are discriminated against. 19% say they are refused care due to their gender nonconformity. 28% say they are being harassed in the medical setting, and even experience violence, says 2%. What is also scary is that 50% of respondents in the USA say they experience a lack of knowledge from their service provider in this drama. So this is not a pretty story, and it is really a good tale of vulnerability. I thought to say something about the evolving terminology. And gender dysphoria sounds like a disease, and it actually means unhappiness with the physical gender. And the patients do not have happiness with the difference between their physical gender and the self-perceived gender where they want to be. So that's what gender dysphoria means. It means they're unhappy with their physical gender, and there's a difference between what they perceive themselves to be and the physical gender that they have. As I mentioned, all genders are assigned. If you deliver a baby, you assign a gender to that baby. That usually happens at birth. And eventually, the large majority in the world have conformity and just carry on with their gender that are assigned or were assigned at birth. I think that to have non-conformity, which means you don't accept your assigned gender in later years, is not really a disease, but it is a lifestyle choice. So I am broadening your terminology from gender dysphoria, which means unhappiness and which sounds like a disease, to non-conformity, which means it is not a disease, but it's a lifestyle choice. And the most common term that we use in this group of people is transgender. So if transgender, or TG, is the most common descriptor that we use when we deal with these patients. Excuse me. So the question is, when is a person transgender? And the real definition is that there must be a marked incongruence or unhappiness between one's experienced or expressed gender and their assigned gender. And it should have been present for at least 6 months duration. It should be manifested with 2 or more of the following events. First thing is the above mentioned marked incongruence between the experienced expressed gender and the appearance of the primary and secondary sexual characteristics. So although they have a specific set of primary and secondary sexual characteristics, they don't see themselves as in that gender, and that is gender nonconformity. Furthermore, they should have a strong desire to be rid of their primary and or secondary sex characteristics due to this marked incongruence. So not only do they not want to be as they are assigned at birth, but they must have a strong desire to get rid of what they have, because they feel that they are in a different gender. The third thing is there must be a strong desire for primary or secondary characteristics of the opposite gender. There must be a strong desire to be of the other gender. There must be a strong desire to be treated as the other gender. And they believe there must be a strong conviction that one has the typical feelings and reactions of the other gender. So can I just say that we've been running a transgender clinic at Steve Biko Academic Hospital for years. And that clinic has probably had more than 150 patients in the clinic system. And this is really true. The patients that come to the clinic have a strong desire to be of the other gender. So if they were born male and they want to be transgender to female, strong desire. They want to be treated as that, and they believe that they have the feelings and reactions of the desired gender. I would like to put to you that the fundamentals of transgender healthcare include the following. Caregivers should be non-judgmental. Now, I will discuss bias later on in this talk, but that addresses this whole thing about non-judgmental. The second fundamental of healthcare is, although transgender is not a disease, it is a phenomenon that requires medical support and treatment. And I'm talking about medical here in the broadest terms. So all aspects of healthcare have a role to play. It is a phenomenon that is, if we don't interact, if we don't impact on it, we have a 45% risk of suicide in this population. We recognize that there are problems with justice, and I'm referring to the ethics concept of justice, namely distributive justice, because the demand for intervention outstrips the supply and the budgets are strained. So unfortunately, the clinic in the Pretoria area, in Steve Biko, as well as in Dr. George Mukare Hospital, have come to a bit of a rattling stop with budgetary constraints. And that was seen especially after the COVID pandemic. But we have to be prepared for the future. The next fundamental is that a team effort is required to achieve the best appropriate care. It is not good that somebody on his own or on her own does something for the benefit of these patients. You have to be part of a team. I still see quite a number of transgender patients. I operate a number of these people, but every single one of them, we ensure that they have all the elements of the team that's looking after them all the time. The other fundamental is that the community should be aware, and support of the community is essential. That's quite difficult to achieve. Our patients also have been victimized by a lot of factors. One of the stories I have to tell is that we have had our patients being thrown off moving taxis because of suspicion of transgender. We've had lots of examples of violence against women, the new women, inside the community, and it's a difficult situation to achieve. What I do know is that we can't ignore the fact of the community and the needs of the community. So let's talk about what's happening to transgender persons who actually manage to get access to the healthcare system. Essential that the team approach is preferred. And the first members of the team are the psychologists and psychiatrists. And this is a simple matter. They do need psychological assessment to exclude psychopathology. But more than that, they use psychological assessment as a crutch to support the changes. And from my perspective, very important to minimize the risk for suicide. So we regard the psychological assessment part as the first step. And if in that assessment, you do not have those characteristics that we listed a couple of slides back, then you are not diagnosed to be transgender, and you cannot then expect further care in the system. Also very important, if patients have gross psychopathology, not necessarily murderers or something like that, but if they have gross psychopathology that can be treated specifically, this is the time when those disorders are treated specifically. And this whole psychological part is carried on for about 1 to 2 years. And after that, the rest of the multidisciplinary team becomes active. So we start off with the psychological background, assessment, support, minimizing the risk for suicide. If I refer to the Pretoria Steve Biko Academic Hospital Unit for transgender, the demographics showed that the mean age at entry into the multidisciplinary clinic is 33 years, which I think you will say, oh, that's quite old. Even more so that most people are aware of transgender from around puberty. But it's very hard to be a high school student where uniforms are worn, where toilet facilities are shared, where sports take place, all these things, and be a gender non-conforming person. Very difficult. So our experience is that people are aware of transgender, but they bite the bullet and carry on until they get to be in their 20s, and then they appear at the different multidisciplinary clinics. Our experience is that there's twice as many male to female than female to male transgender. Our own data, doesn't it look familiar? 42% of our patients had suicide attempts prior to inclusion into the programs. That is quite shocking. Why is it difficult to get access to healthcare? Because initially, the whole matter is kept in secrecy. There's lots of effect of bias, which we will discuss. There's big dramas with budget and with competing major diseases. We see our health rands go into many, many areas where they should go. And part of that is that there's a bit of competition between transgender and other big diseases. So now I would like to talk about affordable medical care for male to female transgender. And the medical care starts with psychiatric and psychological support, as we discussed. And then when the multidisciplinary team kicks in, the second is endocrine support. So the transgender male to female wants estrogens to counteract the natural testosterones. And the high dose estrogens that they take will also assist in breast development. Then we also offer cosmetic support, and that is how to deal with facial hair, because it's male to female. So they have to get rid of facial hair. They have to do something about their voice. They have to hide the Adam's apple, and that they usually do by wearing clothing that protects them to be detected as different, and they have a big Adam's apple while they want to be female. And we have to say that for many persons in this group, these steps will go a long way. Please note that ID changes are essential. So this person who was born male wants to become a female, has a male ID code, the last 3 digits of the ID. They have to change that. Otherwise, they have immense difficulty in opening a credit card, making a loan, dealing with the police at roadblocks, all these things. And they can apply for an ID change after the first and second steps. Psychiatric and endocrine have been reached, have been implemented, and they can apply for an ID change. So we don't only give medical treatment, we also give surgical treatment to male to female. And the most important part of male to female is the performance of a penectomy and an orchidectomy. I would like to put to you that our clinic is not a supporter of the concept of penile inversion. I know there's many people in the country who think that is the easiest way, but we think that we have seen so many complications of penile inversion that we can't advocate that. The biggest thing for male to female transgender is to get rid of male genitalia. Not all of these patients require a new vagina. We calculate that we've done new vaginas for about 2/3 of our male to female transgenders. And for them, it is very important. And we do a vulvoplasty as well to have a very good appearance. It is important that for all transgender patients, the object is to only have the genitalia of the desired gender. If you can just think for a second that you get arrested in the middle of the night, get thrown in jail with the male ID, with a male appearance, until it appears that the genitalia are that of a female. The drama that these people have can't really be described. Then I would like to do the comparative situation, affordable treatment for female to male, also using the team. Now, we know that this is a smaller group than male to female. We start exactly the same with the psychiatric and psychological support, as we described. And then we go on to endocrine support, where in this group of people, we use long-acting injectable testosterones. The one that we choose, if we can get that, is Libido, which we think is a little bit more effective than depo-testosterone. And also, the depo-testosterone is a monthly thing, while Libido is a 3-monthly thing. One of the benefits is that the injectable testosterones will assist to stop the menstrual periods as well, and to help them develop a male pattern facial hair. So pretty soon they start getting a beard and a mustache. This is not an absolute the cessation of menstruation. A patient that we operated today, female to male, despite having been on injectable testosterone for 3 years, was still menstruating every month. Also, we use this opportunity to do male medical care, cholesterol, blood pressure, different organs, and we ask the endocrine people to be the caretakers of that part of the medical care. For a female to male group, the most undesired part of anatomy is breasts. Now, initially, especially if the breasts are not large, cosmetic care with using crepe bandage or using loose clothing or any of these options may be okay, and they may help people considerably. But all and all, the female to male group resent the fact of breasts, and it is much undesired. I also make a point here that ID changes are essential, as we described in the other group as well. So if we talk about the surgical treatment for female to male, the first important thing is mastectomy. Then we as a unit practice hysterovaginectomy and oophorectomy as a required procedure. This is quite important, and it rids the patient from female genitalia. But the bad news of this whole story is that the creation of a new penis is universally quite unsuccessful. Whether it is done by flaps from plastic surgery or by implantation of a silicone rod in a flap, new penis is not a successful operation in the majority of cases. What is interesting is that most people who are female to male want to stand and urinate. This is a fixed social convention, and it is therefore much desired. But unfortunately, to be able to urinate through a new penis is mostly disastrous. It never heals properly. So they can have a new penis, but it doesn't carry tip sensation, it carries basal sensation where the clitoris is, and it doesn't carry the urethra. The urethra also opens at the base. So with that as a sort of a summary of what options we can offer, what are the outcomes of care? In the Pretoria Steve Biko Academic Hospital series, there were 0 suicides after the interventions, from 42% to 0. I think that is fantastic. The complication rate of all the treatments is very low. It is not absent, but it is very low. And what is quite fascinating is that there's very good social adaptability and functioning in their new roles. Many people now form stable relationships. Many get married. Of our male to female patients, we have won many beauty competitions. What is quite fascinating is that there's much improved family adaptation as the years pass. I think the outcomes of care are quite good, and we are very thankful for that. So I would like then to discuss the ethics part. In the first place, let us think about the place of ethics in our thinking. And we have to ask ourselves the question, is ethics outside our core way of thinking, or is it part of the core? And I hope that we will say it is part of the core way of how we see the world and what is our thinking. The second question is, do we see ethics as a tool to use only in uncomfortable situations? Or should ethics be used as a tool in all situations? And clearly, the answer is it should be used in all situations. But the bigger question is, do we do with ethics as they claim with statistics? The joke about statistics is that at least 50% of statistics figures are made up on the spot, which of course is ridiculous, but that is what people say. The alternative is that we are prepared for dealing with issues because of the readiness of our thought processes. And this is what we would like to achieve tonight, is to prepare ourselves to think about the place of ethics in dealing with this difficult situation, because we have already thought about it and we have a prepared thought process. So then we should ask ourselves, if we have troublesome situations. I want to go back one. I apologize for that. What impacts on the way we are thinking about? What impact on our thoughts? And I think there's three. The first is the ethics of the patient, and that is the patient's wishes, dreams, desires, the patient's needs, rights, the patient's self-fulfillment, own beliefs, and the patient's belief on how to live their life. The second is the ethics of the community. The community also has beliefs, feelings, a sense of what is right or wrong. There may be compassion in the community and care in the community. There may be a history in a community, also dreams and desires of a community and rights, and the idea of the community on how people should live their lives. Sometimes also how others should live their lives. I think it's important to mention that the community contains activists as well as non-activists. Activists are very important because they run on their own brand of high energy fuel, and they emphasize factors like empathy, support, the group sense of justice, the group sense of changing the world to a better place, and that is very important. The third group is the ethics of us, the ethical thinking of the caregiver. And of course, this is influenced by all of the above, but it is also very much influenced by bias. When we encounter difficulties, we call on our biases to bolster our responses. Our biases are the inherent thinking and thoughts that we have on how we see life in general. If we talk about transgender, and it looks like it is becoming more common, it is not a new phenomenon. It is an old phenomenon, but these days there's openness and action, which is a new reality of current life. I dispute the idea that transgender numbers are rising because of populism or trendiness. Please remember that modern life is quite complex. If people conform to a general way of life, it is the easy way to make progress. Non-conforming is quite difficult. So now we have a female to male transgender patient who wants to join the military or wants to become a truck driver or wants to be doing heavy industry work. And it is difficult for them. And because of the non-conforming nature that may cause upheaval in their lives. And when we look at our large Steve Biko series of transgender, the non-conformity was there from early childhood, but they suppress it. They only action on it later in life because of the difficulty in living with non-conformity. And I think that the worldwide reports of increasing attendance at transgender care centers, those reports are related to coming out rather than to creation of an all-new popular phenomenon. Then I asked myself, is there a single worldview on gender issues? And there is no single worldview on gender issues. For transgender and other vulnerable groups, I mean, society reacts varyingly, from acceptance of decisions by individuals to, in many countries on our continent, killing of identified persons. I also think that we should understand what vulnerable means. The Oxford English Dictionary says vulnerable means persons or groups of persons that may be wounded or harmed or exposed to damage by weapons or criticism. Vulnerability can be many things. I've listed 4 essential big items: physical vulnerability, social vulnerability, economic vulnerability, attitudinal vulnerability, or all of the above, but there are even more areas of vulnerability. So now for transgender, we know that there's no single worldview. We know it is a vulnerable community. We know that it is under a very sharp lens because of political and religious and community feelings. But I'm concerned that the vulnerability is sometimes forgotten. And the fact that we have to have a special soft spot for vulnerable communities is sometimes forgotten. And there are many things that face the vulnerable community. We have talked about the dramas facing the LGBTQI community and the TG community, and it's numerous and well known. And therefore, the fundamental decision for us, for the healthcare worker, is whether they, the LGBTQI community, should continue to be subjected to these dramas or not. And why is it a difficult issue for us? And most of the problems why this is difficult is because of bias. Bias presents in preconceived opinions in our hearts and preconceived ideas. And our biases largely impact on our decision making. And remember, healthcare professionals are not excluded from being biased. We often approach a problem as if we instinctively already know the solution. And I think, colleagues, we want to be the best doctor or health worker that we can be. And we use our knowledge and our skills and our experience. And I think by and large, our knowledge is good, especially if we actually passed our exams. Our capacity is great, so we keep up with our CPD programs and so on. Our memory is fine, and we have experience. Unfortunately, experience is short and small at first, and it takes a long time to develop. And experience reflects our own version of the worldview. So experience is inherently biased. So now The question is, how do we deal with a person or a situation where we have serious differences between our instincts or our bias and our professional responsibility? And that is the key issue of what we're talking about tonight. The healthcare professional subscribes to two fundamental ethics concepts. The first is the principles of bioethics. And that was neatly classified by Beecham and Childress as, in the first place, respect for patient autonomy. Second place, beneficence, namely to do the good. Third place, non-maleficence, meaning do no harm. And the fourth is distributive justice, and that is being fair to everybody. Those are the four principles of bioethics. We subscribe to that. We also subscribe to the values of professionalism. And those include the values and value systems of respect, of compassion, caring attitude, truthfulness, veracity, honesty, altruism, all these wonderful words. Reflective practice, we have to have that. Accountability, leadership, collegiality, and justice. These are some of the values and value systems that are associated with professionalism. So our ethics basis rests on the principles of bioethics and the values of professionalism. And those things, the principles and the values, support the concept of caregiving, which is what we want to do. The problem lies when there's conflict between caregiver bias and caregiving. In other words, if our instincts say, I rebel against this, we can't do this, and our urge to give caregiving, if there is a conflict there. And please note that the need to dissociate caregiver bias from caregiving happens all over. Now I'm giving you three little examples. Lawyers defending accused murderers, doctors attending injured perpetrators, teachers teaching to kids that insult or threaten them. There are three examples. There's many more, but this is three examples where society demands from us to dissociate caregiver bias from caregiving. And I would like to say to you tonight that the intrinsic likes and dislikes of the professional cannot override the obligation to provide care, whether you like it or not. Patients are regarded as patients. Vulnerabilities must be recognized where they exist, and care is given to our patients regardless of our own biases. I'm not saying this is all easy, but that is lofty ideals. Let's talk a bit about distributive justice. The community is very sensitive to justice and equity, equality, and shared values. If a community feels they've been left behind, it takes them a few months and then they write a letter to the government. We should know that when we use health dollars, health rands, for the care of transgender patients, the care offered is not frivolous or supporting a fad. Care is designed to improve the quality of life of the affected individuals. And as we said before, serious situations require serious actions. And in the Steve Biko series of transgender patients, 42% of patients having had suicide attempts prior to being included in the multidisciplinary treatment program. After inclusion into the program, the attempted suicide rate dropped to 0%. This is not Mickey Mouse, and it fulfills the needs of the principle of distributive justice. Chairperson, I'm concluding with the following dreams to say The transgender person is a member of society, a citizen of our country. It is somebody's child, it is somebody's sibling, and is deserving of care following principles and values of bioethics. So what do we do when we deal with a transgender person? We do what we do. We follow our schema of clinical care. That is things like history, examination, differential diagnosis, special investigations, and a treatment plan. We pay huge attention to respect for autonomy of the patient, of beneficence where we do the good, and non-maleficence where we do no harm. And we are sensitive around issues of justice. And we always remember to adhere to the value system of the professional. The more vulnerable the patient community, the more caregivers have to walk the extra mile. Caregiving always supersedes caregiver bias. And my last word is our patients are our patients. Thank you very much, everybody. I am in your hands if you want to have discussion. That will be 100%. Thank you very much.
Thank you, Prof. That was quite empowering, at least for me. As a platform, we have a simple mission, which is to transform one health worker at a time. So today, just at my level, Prof, that has been achieved. Billy?
Thank you so much, Prof. I agree with Dr. Mawela. I think this was really a powerful, very insightful talk. It's a very difficult topic, but Prof, you've really summarized it and made it so easy for us to understand. And I think my take-home message is that it's our responsibility to observe all the ethical principles and never to be biased.
Yes.
Towards our required care, because as Prof said,
I believe
it's not a new thing. It's always been there, but people, we should be ready to. Okay, thanks, Alice. And the bandwidth is a problem. So thank you so much, Prof. I must just share my short experience with a couple, both of them born female. So they come to me for antenatal care, married, they've got kids, they are now expecting antenatally, and fortunately they've delivered the babies well. Now the partner that identifies as a male is really demanding that I give or him testosterone. I unfortunately declined that option. I explained to him that, you know, it's quite a process. You don't just start. It needs it, as Prof said. And unfortunately, you know, the Steve Biko Clinic at this point is only on a waiting list thing. So there's many, and I've seen a few of our colleagues on the platform as well attesting to the fact that they are transgender, they've undergone some kind of treatment, of course, with some challenges with our health system, not really supportive of people who identify as transgender. So yeah, it's a big topic, and I think the more we talk about it, the more people become aware, and the more perhaps the service becomes widely available. There's a few comments and questions, Dr. Mawela, if you may also assist me, but I've seen in the chat, I think this is a colleague who's at the primary healthcare level who says, now when I'm faced with such a person or a patient who identifies themselves or who say they are transgender and they seek help, what would be the way forward? Where do they refer to? The urologist, the gynecologist? Who do they send to? As well as baseline workup, is there any investigations that they have to do, and anything that they can do at that point to support such a patient? I don't know if Prof, you would like to comment on that, please.
I would like to comment by saying that I think the worst thing we can do is to fly alone, is to fly by night. I will tell you, I was visiting professor in New York at Cornell University, and as I was talking about transgender, one of the big guys from Cornell stood up and said, "Yes, I've treated the patient. We have now been in a journey for 10 years, but nothing has actually happened." So I think we can get into pitfalls. The first thing, in my opinion, is to be sure that they are not going to kill themselves. And you can never be sure about that. But with the help of psychology and psychiatry, you can make that a lot better. You can make it better to try to avoid a lethal situation. The second thing is, people need enormous amounts of support. So there's one question here that says the patients get irritated when we refer them to psychologists and they say, "You can't call me crazy." That is one of the biases on the patient side that we have to overcome, because the idea of the psychologist or psychiatrist is assisting the patient. They must make life better for these patients. One of the other questions is one of the participants say transgender women of 3 years standing changed the idea. Medical aid does not want to get hormones, and the question was, is that all right? Can I say to you, my dear patient, can I say to you, nobody understands totally the way the medical aids make decisions. And our people refuse to read the fine print of the contracts they sign with the medical aid. I think if we join the medical aid, we must be very sure that all the skeletons are removed from the cupboard, that we know what will be on the small print, and then maybe we can get to a real solution. It's interesting, you will not believe it, but in this year, 2022, I've operated on 3 transgender patients in my private practice in Femina, supported by their medical aid, which is GEMS. If you're surprised by that, I'm glad. Billy, should I go on with 1 or 2 of these questions?
Yes, Prof,
please. Yes, Prof. Actually, we are listening to you as you talk, about your experience. I think you can continue to Dimakato Ramogole, who says, do you ever get cases of patients who want to revert to their original status?
Yeah, this is a critical question, not because of our experience in South Africa, but because of the experience in the UK, where a young person who got male to female at age 16, which is earlier than we do things here, then after a few years took the health authority to court by saying, "You did not counsel me properly, I want a reversal." Now, I think it is a good example of one of these disastrous situations where the confusion of the poor patient is so much to the forefront that I'm even more sorry for them than I usually am. And in South Africa, we are not aware of anybody. in my 30 years on this, I've not had any patient who wanted the reversal. In fact, the patients are as happy as you can believe. The biggest problem with reversal is that some of them have surgical complications, like church spire type of vagina after a penile inversion and things like that. So that makes them want to have a better situation, and a lot of them can get better with a bit of treatment.
So Prof, with the other disciplines, I see someone from speech therapy says, but I could be involved to help with the voice. Who else needs to be involved, Prof? I think it's a real multidisciplinary approach this time around.
Absolutely. For me, the be all and end all is what is happening as the team is looking after the patient. The transgender person will want a desired voice level, and then sometimes they abuse their cords, like this contributor is saying. I think the speech therapist should be in earlier than late. And it's a valuable partnership. So please never think that we don't respect all the things that that our colleagues from all disciplines in healthcare can offer. In addition to speech therapy, we also talked a little bit about the beauty therapists, and I mean, there's so many other. Lesego, you wanted to say?
No, it's okay. I think it's Billy.
Oh.
No, it's all right, Dr. Mawela. It's just my connection was misbehaving a bit. I just got reconnected. Thank you, Prof.
Okay.
I think, Prof, you may proceed if you're able to respond to any of the other questions there on the Q&A or the chat.
Maybe before that, I want to try and take a hand. Sharon, are you able to hear us? Maybe you may unmute. Sharon?
Sharon is muted, so if Sharon can just unmute, then we will probably hear her.
All right. I think I will let you know, Prof, when she's back. And then Pumla is asking, does it mean that a transgender from male to female will not be able to conceive because he does not have a uterus?
Yes. In South Africa, there's not been a successful uterine transplant. There's been about 150 successful uterine transplants in the world. The problem is that when they get transplanted, the venous drainage is the biggest problem. So it is not the easy situation, and they have rejection reactions. So unfortunately, the drama about having offspring is restricted to genetic genes and not carrying the babies. So we've got several patients where the participants or the persons donated their own genes or had it frozen by the infertility people, and then eventually had surrogate babies. So that is the answer there. I also referred to the same participant where I said that I've operated at least 3 people this year who were supported by GEMS, and I think that is quite good.
And Dr. Muriga is saying here, hey, this topic requires a major mental shift, Prof.
Yes.
And she's talking about the plus on the LGBTQ to say, does that mean there's still more, which is undefined?
Yeah, or in process, or a little bit changing and maybe not yet completely made up their mind. I absolutely agree that it requires from us a major shift in the way we look at patients. We are not supporting a fad. We're trying to save lives. And I think that is very important.
Yeah, Prof, I saw a number of questions around availability of the services in the country. You have mentioned 2, at least in Gauteng.
Yes,
Are
there
there
is
other
a
big
service
centers?
in Cape Town.
Okay.
And I think from time to time, I was phoned the other day from Barra, from Kusani Barra Hospital, and they seemingly had a patient that they wanted to operate. So I think from time to time, there are people in other places, maybe the Free State, maybe in the Joburg circuit, that are also doing contact with all these people. The Joburg circuit was quite famous for its psychology and psychiatric support of a lot of people, and I think they have not lost that skill. I am not sure how many public health facilities are available, but the demand is quite great. It is at the moment outstripping the availability in this difficult budget era. That is quite rough. And if I just look at some of the other questions, there's one that says, where does the patient start for initial care for the start of their transition? And there's another one that says, what is the starting point from a primary healthcare perspective, or what is happening in Nelspruit? I can't answer the last
That's
one
where I'm at.
because I don't know.
Yes.
But in principle, where do you start? What is the referral pathway? I think it is important to exclude the most lethal things, and at some point in time, to waltz through a psychologist and or psychiatrist is a critical issue. And then after that, we're still talking about very affordable treatment. When we talk about endocrine, it is affordable. I mean, you know, the cost of a packet of estrogen pills, or the injection for depot, testosterone, whatever, is not going to bring down the house. So that can be done and care can be given. I've seen persons in a transition phase who are getting their basic help from primary healthcare facilities, where the people who run the facilities are actually very, very friendly and very careful about this whole situation. Now, there's one, Femi Olukurum says, now I can't see that anymore, but it says, is the recreated vagina backed with sensation? Now, what we do in our unit is to use a sigmoid colon new vagina. We have also in the past used a Mackendale operation where we use a skin graft. That was invariably where a vagina got blocked and fibrotic, so we had to recreate it. If we use the sigmoid colon as a new vagina, it has inherent sensation, and it it also has clitoral sensation. So the patients have normal intercourse and they feel quite good about that. Then there's a question on somebody who will want to know about gay and lesbian and transgender. Now, traditional terminology says that the gay community is the male same-sex community, and lesbian is the female same-sex community. And transgender is the community where you want to change the gender that you are born with to the gender where you want to be. Then there's a question about successes after uterine transplant. in the research setting, yes, about half of people who had a uterine transplant could have a pregnancy. Not all, about a half. But we watch this space very carefully. And then there's a question, what are the most common side effects or challenges individuals have after a vulvoplasty? And how can they be supported by their partners? The idea of the vulvoplasty is to look like the desired gender. So we do not want somebody from male to female just to have a chopped off penis and testes, and then there's nothing like looking like a female. So we do a vulvoplasty where we create labia majora, labia minora, proper vaginal opening, and we are quite sure. And I can only answer what patients tell me, and I know of a lot of married transgender patients who says their husband never knew that they had anything done with them because the vulvoplasty makes them look very good.
Thanks, Prof.
Question about inclusion or exclusion criteria for a patient requesting TG. That, for me, is age determinant, and this is the school children question that Sharon wants to talk about. The problem is that the difficult environment in school and with school chommies and so on is very difficult to have in a program, and sometimes that I think is exclusion. I know in America there's a group that has a feeling that you should start the day after a child wants to be different, but we think that you should probably be able to vote before you get surgery. And that answers also the anonymous question about what is a suitable age.
Yes, Prof, is there something called non-binary? I don't know what that is. I'm not sure what the question means in this space.
Maybe we should have a little bit more information about that.
Yes, Prof. Prof, there's two clinicians that you have trained here on the platform. I just want them to say hi to you. The first one is David Mvula from Namibia. I hope, David, today your network is good.
Can you hear me, Lesam?
Hello, David.
Yes, we can
hear you. Good evening, Prof. How are you?
I'm all right, and you?
Good to see you, Prof.
Yes, and I'm glad that you got to play in the World Cup for cricket.
Of course, of course. We'll be playing at the Rugby World Cup very soon as well.
I like that. Yeah,
yes, Prof.
David, nice to hear from you. Keep well, man.
It's good to hear from you, Prof, as always. And we are very fortunate to have had an opportunity to be at the transgender clinic, and we have seen the work that has been done. And we really appreciate the effort and the teaching that we gathered from that clinic. And the topic, as you can see, the interest, it is really quite a very informative talk. Thank you very, very much, Prof.
Thank you, David. Nice to hear from you.
Yes. And there's Tepo, Prof, as well.
How about you, Tepo?
As we close, Tepo, are you able to hear us?
Tepo is muted. But I'm so glad to see his name. I'm so glad. Oh, there
you
are.
Evening, Prof.
How are you?
Good, thanks. Yourself?
Fine. Fine.
Great, great.
Tonight.
I've really enjoyed the talk, and this is one of the subjects that are very close to my heart. Prof, you might remember that I did say one of my dreams is in future to do one of transgender surgeries with you. But I really enjoyed this evening's talk, and there's really
still carrying on with that, so don't give up, no.
No, absolutely, Prof. I will definitely not give up. But yeah, thank you for everything. Thanks for all the training and the wisdom that we continue to learn from you.
Super nice to have you here tonight. Thank you very much. I appreciate it.
Thank you,
Prof.
Prof.
Billy,
Billy,
I
would you
know
like to?
you're moving towards the end, but can I just say, Lesego, that
Yes.
there was a comment that somebody flashed by that said transgender does not
Is not-
include gay and lesbian, and that is, of course, correct.
Yes.
Transgender, the idea is that you want to change the gender from where you are. Gay and lesbian are terms that is used for same-sex relationships in males and females respectively. So that I'm just agreeing with the person who flashed the comment to say that it is not, transgender is a term reserved for when the gender is to be changed. Thank you for that.
Thank you, Prof. And maybe let's take Femi's question. I'm not sure, is he saying, is disclosure to a new male partner a problem of a male who has undergone surgery? The disclosure process, how does that work, Prof?
Yeah, it is difficult. It is very difficult. And people live so completely into their new role that they don't talk too much about it. But if it is a new male partner of a male who had undergone surgery, that is not a typical situation for transgender, because the transgender male who has undergone surgery is not gay. That person is heterosexual, although the way of the mind is a difficult thing to understand.